Good afternoon, everyone. I would like to warmly welcome you to today's webinar titled Addressing the Burden of STIs Among Migrants and Refugees in the MENA, Challenges and Lessons Learned. This webinar is hosted by the Refugee and the Migrant Health Program through the Academy Division at the Global Health Institute at the American University of Beirut. Thank you all for your interest and for joining us today to discuss this public health issues that affects vulnerable and displaced population. We are pleased to have with us our distinguished speaker, Dr. Ismael Maatouk. Dr. Maatouk is a global STIs leader and dermatologist with over 15 years of experience at the intersection of clinical practice and public health and sexual health and STIs. He currently serves as a medical officer on STIs at the WHO quarters, where he drives global STI policy, leads STI antimicrobial resistance surveillance, and advances evidence-based strategies for prevention, testing, and treatment. He has spearheaded the global antimicrobial resistance surveillance for gonorrhea, influencing WHO treatment guidelines, and has worked on integrating STI services into HIV and community health systems in low and middle income countries worldwide. Dr. Maatouk has published over 100 peer-reviewed articles in the fields of dermatology, STIs, migrants, and sexual health. Prior to joining WHO, he served for 7 years as the national STIs focal point in Lebanon's National AIDS Program, where he led the national rollout of PrEP, HIV self-testing, monitoring and evaluation of HIV and STIs, and the integration of STI services across Sentinel community and outreach clinics. He also holds an appointment as Adjunct Associate Professor at the Department of Dermatology, Faculty of Medicine at the American University of Beirut. Dr. Maatouk, thank you for taking the time to be with us today and for sharing your expertise and experience with our audience. Without further delays, the floor is yours.
Thank you so much, and thanks for having me among you. I mean, this is always a pleasure to be talking about STIs and also migrants and refugees. We will go through the agenda just to give you a little bit of sense about STIs and how these infections are a public health burden. And then we will also talk at the second stage about the definitions and figures on mobility in general. Then we will overview the intersection between STIs and wars, and then overview the burden of STIs in refugees at the global level with certain country experiences, and then we'll move ahead to solutions and next steps, and then I will make sure to give 10 minutes toward the end or even more for a certain Q&A and further discussions. So STIs, I mean, my favorite topic, this is a public health burden that is present worldwide. So in WHO, we published the estimations of new cases of 4 curable STIs, only 4 in 2020. And we had seen that trichomoniasis, chlamydia, gonorrhea are all very high. We're talking about 374 million new cases of these infections on an annual basis. And to make it simple, on a daily basis, we have 1 million STI acquired, one of these 4 acquired anywhere and everywhere. We're talking also about some other STIs which are more viral, such as HSV, herpes. Millions and millions are affected. And we know very well that there are high rates in the general population, but there are even higher rates among some key populations, what we call them in WHO key populations, the populations or the communities of men who have sex with men, female sex workers, trans and other people in prison, but also migrants and refugees. So this is the first intersection, and I'm giving you some hints here. Regarding STIs, one of the main problems, of course, is the monitoring, because many people escape the cascade of care. So by going to the pharmacy or by getting any over-the-counter antibiotic in several settings, not only in Lebanon, that's why monitoring is always challenging. However, if we look at countries with very strict and high income countries where surveillance is really strong, we look at this list of countries, the majority of which are in Europe, we will see that through the years, we had an increase in the trends of gonorrhea. And this is just an example. I could show the same for syphilis, for chlamydia, for trichomoniasis. So we are constantly on increasing reported numbers of cases of STIs or selected STIs in few countries. And of course, if STIs are increasing in Greece, it doesn't mean that they are not increasing in other parts of the world. And why is it an important topic? Because of course we have, I mean, selectively syphilis and congenital syphilis. This is only one pathogen, and if you look at the numbers, we see that in 2022 there was an increase of 2 million compared to 2020. And the major risk here is the congenital syphilis, where we have adverse pregnancy outcomes and adverse neonatal outcomes. Of course, because people do not get tested, or whereas they should, of course, pregnant women should get tested, and they don't get the adequate treatment on time at the same day in the clinic. So these are challenges, just to give you an idea about one pathogen here, which is syphilis. As I mentioned before, it's a global health problem and burden of STIs. And if we look at chlamydia, gonorrhea, and syphilis, we will see that, as I said, it's a general public health problem. It affects equally men, women, with a little bit of differences. However, they are much more concentrated in key populations defined as men who have sex with men, female sex workers, people who go to prison, transgender, etc., etc. And it includes, of course, migrants and other populations. So let's move now to the viral STIs, HSV. It's one of the very common pathogens, and we're talking here about millions, over 200 million adults with prevalent genital ulcer disease due to HSV1 and 2. And of course, it makes it more complicated because we have two types, and there is an overlapping between the genital HSV and other anatomical regions. Of course, you will see here that there are differences according to geography. It all relies on how we are capturing data through surveillance. Of course, for HSV, it's almost complicated and almost impossible to have a surveillance for HSV, so we rely on estimations. And because of the lack of data coming from several regions, and our regions in the Eastern Mediterranean is one of them, we don't have a very clear idea about what's happening. But again, as I said, if herpes is frequent and extremely frequent everywhere, we have no idea why it shouldn't be also frequent in the Middle East. HPV is another huge topic, and we have, as per our estimations, 1 in 7 women estimated to have prevalent HPV infection. For years, men thought that they were more protected, and in fact, numbers and figures there are even more scary, because 1/3 of men have any HPV type, and 1/5 have a high-risk HPV. And of course, we're talking here about a very labile virus, which is HPV, with over 200 subtypes that be transmitted through any kind of sexual relationships. Now, this is for some of the STIs. One of the major other concerns is about antimicrobial resistance, and we have in WHO EGASP, what we call it EGASP. It is the Enhanced Gonococcal Antimicrobial Surveillance Program. It's a sentinel surveillance distributed across several, I mean, the majority of WHO regions and several countries, and we have seen over 12, and we have seen that the overall resistance of gonorrhea to ceftriaxone is roughly 4%, and ceftriaxone, for your info, is the last treatment that we can give to gonorrhea according to our recent guidelines. Cefixime is roughly 10%, azithromycin 4%, ciprofloxacin 96%. So we are talking here about a pathogen that is really resistant to antimicrobials. We have other surveillance channels to the same pathogen, not fully dedicated to gonorrhea, and I feel and I think that many of you are aware of the GLASS and GASP. These are networks of reporting of surveillance of AMR in general. And whenever we have a country that provides culture through their national laboratories, we ask them usually to report to us what's happening with the gonorrhea resistance. And according to the number of countries reporting, they are different, of course, for each antibiotic. Some countries do for ceftriaxone only, some others for other antibiotics. I'm talking only about gonorrhea. And you see there's a difference in the number of countries reporting, but however, we have a high number of countries who had reported at least one isolate with resistance or decreased susceptibility to ceftriaxone, for instance, 39%. This is really scary because this means that the burden of antimicrobial resistance for gonorrhea is really very high. And this is, as I said, the last antibiotic option that can be given for people who have gonorrhea. And we're talking about a 40% resistance. For cefixime, it's 50%. I know cefixime is not widely used in Lebanon. This is good. Azithromycin, 88%. So for people, I keep saying this, people who go to pharmacies to get azithromycin at any or any generic antibiotic of the same category will not work. This antibiotic will not work for gonorrhea. In 88% of the reporting countries, we had resistance for azithromycin. And for ciprofloxacin, I hope nobody is still using ciprofloxacin to treat gonorrhea. This was a historic treatment in 2006 or 5. We started having resistances in terms of gonorrhea. So this is one aspect of an STI with high resistance, and this is to show you that each STI has really very particular problems and burdens worldwide. In the gonorrhea space as well, we have a circulating clone, FC428, which is becoming old now because it had acquired further mutations to become even more resistant. And this clone was first identified in Japan, 2009, then immediately spread to other countries in France and Spain, and then through Asia, as you see in the map. It's existent. It's widespread in China and surrounding countries, Vietnam, Cambodia, Laos, Philippines, and other countries, even Australia. And because of the international travels, this is the only factor actually that was identified through the reports that we saw in the UK, in Ireland, in France. People were going for touristic leisure and pleasure, and then they were coming back with a certain resistant gonococci. But what are countries doing? Actually, countries are trying their best to update their national management guidelines for STIs. As you see here, 97% of countries have reported to WHO that they have a national case management guidelines, 15% of which are updated in 2020 or earlier. And we have because of our advocacy and our pressure with member states, we have tried to update many of the other guidelines or in the other countries and settings. The real problem is not about updating guidelines in STIs. It's mainly about the implementation of the guidelines in the clinical setting. So we know, for instance, that a country has updated the guidelines, but we don't know what's happening at clinical level, whether the training or the uptake of these guidelines was really effective across the clinics at PHC level or private or public sectors in the country. And this is really huge because we cannot capture the indicator about the implementation and the effective implementation in each clinic. To add complication on this, STIs themselves have a very weird natural history because I keep having this discussion with colleagues who are responsible, for instance, for TB or for HIV. It's quite direct. There are people who are infected, we test them, they are positive, they get treated, and they are under control. For STIs, the situation is a little bit different because the total number of infected people is very wide. A minority is symptomatic, the majority are asymptomatic. Among those who are symptomatic, a minority would present to care at PHC level or at private public clinics. Whenever they are requested to take a treatment, some of them are not adherent, some of them get reinfected. So the main people who get treated and cured from the STI, and we're talking about non-viral STIs, it's a very minimal number or percentage compared to the total people who are infected and those who are asymptomatic. So the natural history of STIs is also challenging, which adds burden on all the factors that I mentioned before. And to give you, this is one example about gonorrhea. For instance, you will see that, or any infection actually, we have three sites, oral, urethral, anal, for instance, that can be infected, and infections there can be symptomatic or asymptomatic. If people get testing and so tested and diagnosed, they might get a treatment. Sometimes patients are asked to come back after a week, for instance, to get the results of the NAT or the PCR, which adds a lot of complication. So we're talking really about a challenging natural history, but of course there are several steps that can help the provider to control STIs at national or global level. And the populations affected are usually any person belonging to the general population, but we have a special focus for pregnant women, newborns, children, adolescents, cisgender, heterosexual adults, people who belong to the gender diverse populations or sexual diverse or minorities populations. And there are other populations depending on the setting. So maybe we don't have them in Lebanon or in the Middle East, but we have them in many other settings. So for instance, in Canada, we have very specific populations like the natives. So each country has a specific setting of populations who can be or who are at risk of getting STIs much more than the others. And the main key factor is access to services. This is the main modulator of having a population more affected or less by STIs. So among the risk factor of STIs, and this is an old paper from the 90s, we had, I mean, the authors had cited several factors affecting the prevalence, like the inadequate sex education, we know it, other practices, behaviors, etc. And it was mentioned the urbanization and other migration. I know that maybe in the 90s it wasn't as trendy as now, unfortunately. I'm talking about migration. Now it's much more frequent. And this will lead us to the second part of the presentation about mobility in general and what do we call people who are mobile. Actually, we try to divide them. There are several definitions. I'm trying here to capture the mostly used definitions. So we classify them into refugees, who are people who flee their homes, cross an international border and cannot return because they fear their lives are in danger. We have the internally displaced people or persons who flee their homes for the same reasons, but do not cross an international border. The asylum seekers, who are people who flee their homes and claim they are refugees, but their status has not yet been definitely determined. And we have the migrants, who are like me, who voluntarily left their homes to settle in another region or country for a variety of different reasons. So these are really the four classic definitions, but I know and I'm aware that the literature is bringing us much more definitions now, but we really don't need to dilute, in my opinion, the definitions or the individuals, and we really need to talk, in my opinion, about the mobile populations. We know that each subpopulation has specific characteristics, but we need carefully to talk about mobile populations in general. And why they are mobile? Of course, because of security reasons. They do not want to stay home, or they need to leave their houses. However, it facilitates a lot to have sea, because the Mediterranean Sea has been known historically for 2,000 years at least to be a carrier of migrants, and this is how many factors, or like the alphabets or other very good inventions in the world, changed the world. However, it remains also a tool for people, or a transport tool for people to move around different countries to seek better lives and more security. And if we look around us, I mean, no need to tell you about what's happening in the world. But just let's look at the numbers. We know that 122 million people were forced to flee in 2024. There were 73.5 million internally displaced people, among which, of course, there are people who unfortunately belong to Lebanon because of the conflict or the war that happened last year. This is just an example. 42.7 million refugees around the world. And if we look at the geographic map, I couldn't really capture what's happening across different continents and countries. In each continent, almost, we have a certain conflict that is resulting in refugees, internally displaced, asylum seekers, etc. And we tried to look into with Professor Aldo Morone, who is an expert in migration and STIs and dermatology in general. We tried to look at this topic like a few years ago to try to set some steps for people and who are on the mobility and try to identify from the literature the factors that affect each step of this migration phase. So we know that there are four main phases: the pre-departure, the travel or interception, the destination, and then the return in some cases. And this is a +1 phase. And each of these phases has specific characteristics. So for the pre-departure, for instance, we have the biological characteristics. If people were already living with HIV, for instance, or had syphilis before even departing. We have the local patterns of chronic conditions, whether they know it or not. We have the pathogens distribution. Many times we see people leaving a country, but we know nothing about the HIV situation in this country, for instance. The environmental factors, political and socioeconomic circumstances which can affect their sexual behavior, and the depletion of healthcare workers. So some people might come from a country where you have absolutely no healthcare workers enough at an enough number to take care of health at a public level. Then we have the destination characteristics. Of course, we have here the socioeconomic deprivation, the access to care. This is one of the most important characteristic. Legal status, occupational risk. So someone who is illegally present in a country cannot access care. So you see the intersection or the interconnection between these different characteristics. The travel and or interception is very important, and I mean, even in the literature, we miss capturing what's happening during the travel or interception, where some people really spend a lot of time, a very long duration of time during the travel. But here we have a lot of challenges as well, like the sexual violence, human trafficking, poor living conditions, human rights violations, and we have also the travel conditions themselves. And then for the return, it's not always easy because we have the pre-travel advice, the poor medical assistance during the travel, and the reduced immunity against the local pathogens in the hosting or the country where people are returning to. So we have these four steps or phases, but we have very specific characteristics for each of them. Now, what's the link between STIs and war? I mean, after World War II, there was a certain messages or plethora of messages that were mediatized, trying to picture STIs, and specifically, for instance, here syphilis or gonorrhea, who were really very high after World War II or during World War II. People were trying to make the STIs look, or venereal diseases, as they used to call them, as enemies. So they give you, these posters give you the flair of a certain war. But actually, the problem is much more deep because of war, people lose their houses. There is a full destruction of medical infrastructure, as an example, the loss of financial stability, the migration of doctors, the poverty, the stress, which all contribute to other factors such as the decrease in access to healthcare, difficult access to contraception or to protection in general by using condoms, for instance, drug use because people are under stress, sexual violence because of many other factors. So you see all these ideas or themes contribute to a certain behavioral disorders and it facilitates the spread of sexually transmitted infections. And this leads us, so we're not talking about an isolated disease because it's not one disease. There are many infections in STIs. So we're talking about a set of infections that are easily transmitted, but the factors are really so multiple that we go through the social determinants of health. And this is very important. This systematic review actually comes from colleagues who work in the Middle East region. And so they have identified how migration is recognized as a social determinant of health. And there are conditions surrounding migration that lead to health inequalities, actually, and increase the health risk and consequently the negative health outcomes. And when we try to look into the social determinants of health, we try to, because there are many factors, and I mentioned many of them, but we can mention even more. We try to understand and to classify them into those that are really proximal, so belonging to the individual, and those that are distal and that belong to the general socioeconomic and environmental condition. And according to this systematic review that I mentioned, what were the challenges faced by migrants? And this paper has been published in 2021 because at that time, the Middle East or the WHO region of Eastern Mediterranean was specifically touched by the negatively, of course, touched by the migration flow and the refugee. So that's why colleagues in WHO and other scholars were trying to identify some factors that contribute to the social and structural determinants, specifically of sexual and reproductive health and rights. And among these factors identified, we can cite economic crisis, hostile discourse on migration, the limited legal entitlements that I mentioned before, the inadequate resources and financial barriers of people and of the hosting country, the poor living and working conditions, the cultural and linguistic barriers, and the stigma and discrimination. So these factors, these six determinants can really be foggy for some people, but if we don't touch base on them and if we don't try to resolve them, the problem of migration slash STI will remain very important at the national level. And the negative health outcomes, we're talking here about STIs, but we don't have to forget that we are talking about humans. So these humans are at increased risk of mental health, negative mental health outcomes such as anxiety, minimum depression, PTSD, or others. But there are also the higher risk of chronic conditions, the exposure to infectious diseases in general, not necessarily those transmitted through sex, and the negative overall well-being and health equity. Now, what is the burden of STIs in refugees at a global level? And this is one of the challenges of this topic, because if we look at the literature, I had challenges to identify what studies to show you, because many studies and the majority of studies would come from very specific areas of the world. So here, for instance, in this study that I'm mentioning, or a systematic review that I'm showing here, we have Europe. So 21 studies, 14 out of 21 studies come from Europe. And then you have North America and then Australia. What I'm trying to say is, independent of where people or migrants or refugees are coming from, the hosting countries that are reporting about this problem and that are doing studies, executing studies, are really known at a global perspective. So, for instance, in this systematic review, we have the majority coming from USA, Germany, Italy, Finland, UK, Spain, etc. Whereas the refugees or the people studied come from very different settings in the world. And what did this systematic review show us in terms of prevalence of STIs? It showed us that the highest prevalence of HIV, syphilis, and hepatitis B come from refugees or mobile populations from sub-Saharan Africa. This does not mean, of course, that a person coming from the Middle East is not at higher prevalence of HIV, syphilis, and hepatitis B. However, this is what the systematic review could capture. Chlamydia, for instance, they identified that the highest prevalence comes from the Middle East and Eastern Europe, and the increased STI prevalence in general was linked to history of STIs. People who had STIs are at higher risk of getting a new STI, torture, blood transfusion, and being of African origin. And if you look further into the literature of this topic, specifically about STIs, and I'm really talking about sexually transmitted infections, not HIV, not SRH, I'm talking specifically about those pathogens, you will see that there are really regional disparities and country disparities. So each region will tell us a story that is different from the other one. But the universal intervention that can work based on this systematic review is the targeted and tailored screening for STI. And this is the best way to start resolving the problem of STIs in refugees and migrants, to target and tailor the screening, the testing at country or region of origin, and at individual, and of course to address the individual risk factors. If people are having unprotected sex, we need to add more preventive tools. If people lack testing, we need to offer testing. If people are being tested, diagnosed, but do not have access to treatment, we should provide treatment. If the problem is elsewhere, we have to address the problem that is elsewhere in the basket of problems that I mentioned and that belong to the social determinants of health. Going back to some regional disparities, and now we will overview some papers from the literature. So this is a systematic review done by Rina Mumtaz, our colleague in the Faculty of Health Science, and they had they identified 37 eligible studies, and they acknowledge, even in the paper, that only one study was conducted among Syrian refugees. So it captures, this systematic review captures what's happening in the literature as well. And they identified people or refugees who are African or from Southeast Asia that were represented the most. So, and in light with this interpretation or setting or background, we need to interpret the rates that we are seeing for syphilis. It makes sense because the majority of refugees that were represented are African, where syphilis is already very prevalent there. Neisseria gonorrhea 0.6%, chlamydia 0.5%, and trichomoniasis 29.3%. This is the pooled prevalence. However, if you look at the percentage of studies, you will see only 4% of studies touched based on Trichomoniasis vaginalis, Trichomonas vaginalis, which is one of the most frequent pathogens in women. So this is just to give you an idea about the regional disparities and the disparities across the studies as well. So what are the methodological limitations of the studies in general? Because we can show now so many papers and so many systematic reviews, they all have the same limitations almost, which is the geographic disparity. Some of them have representativeness, some others do not. Depending on the origin of countries, we have more representativeness or not. The chronologic disparity. So as I mentioned before, there are some recent conflicts, such as the one in Ukraine, the one in the occupied Palestinian territories, that are not captured in the literature. The findings reported are usually based on the regions of origin, not on the country level data. The time spent by the refugees in transit is rarely reported. I could not find really very strong studies related to the transit experiences. And of course, as I mentioned before, the STI reporting and testing is not universal in countries because it's really hard to capture a very strong surveillance in low and middle income countries. Excuse me. So now let's move to more country experiences to learn more about what's happening in countries. So if we serve some studies from Asia, for instance, we will see that the barriers to accessing healthcare is really not surprising. So we have the distance and availability of health services, the spousal consent of health seeking, and the out-of-pocket health expenditure. Of course, on top of the cultural and religious beliefs and the stigmatization. And the consequences are the same. We have the poor poor family planning, poor HIV-related health knowledge and transmission, and the high psychological distress. And here as well, we need targeted interventions. So, for instance, for these two papers that I'm showing on the slide, they mentioned that having the UNHCR card would be a very positive and targeted interventions, and they have identified it as very useful. Whereas in other countries, we know that the political surrounding can be really challenging in this regard. We have also the availability of health clinics within camps. And we know, for instance, from experience in Lebanon, how even the availability of health clinics within camps can be very useful in Lebanon, but not widely because we had a different experience in our country. So this is to show you just examples of how the targeted interventions should really target the social determinants of health in the country. And this is where the exercise should start. In Europe, for instance, they mention other determinants like the economic crisis, the legal entitlements and barriers, the inadequate resources for migrant health, the poor living and working conditions, again with cultural, linguistic barriers and stigma and discrimination. And they also talk about targeted policy making and planning, because there are some of the social determinants of health that can be reversed through discussions with politicians, whereas it can be much more challenging in other settings and in Lebanon as well, because addressing structural challenges or problems or issues can be much more challenging in low and middle income countries. But again, they mention in Europe the need for an improvement of the STI HIV awareness at the migrant level or refugees, but also the increase in testing and early service utilization. I will also show some here. The purpose is to show you the map and to see that it's not really about offering a test, it's about accessing the test. If you look at the map, you will see that there is a certain line between West and East Europe, and this is how you know that the availability of STI testing for undocumented migrants in EU can really be different across countries and across sub-regions within the same continent. And this, of course, relies on huge political decision at country level. So imagine this is one problem. Imagine having this problem across or outside of the European continent. So many scholars in Europe talk about several factors, and the key factors identified for the increase of STIs in migrants are the separation from partners and the high-risk sexual networks and the limited preventive access. And whenever we observe the literature, we will see that each country has a different experience and each continent has a different experience and will provide us with different factors that contribute to the increase of STIs. In Malta, for instance, and this is where Professor Padovese is really working on migrants, and I had the chance to work with her on migrants in Lebanon and Malta as well. She had identified with her team some barriers to healthcare access for migrant populations in Malta, such as legal status, language barriers. So for them, the language barriers, and she keeps telling me the language barriers is one of the most important factors determining STIs and HIV as to her experience, the cultural differences, and the lack of information and education. Another paper from Malta and from the same group, actually, just to give some numbers, 143 migrants took part in this study. It was a study that, and the paper was published in 2022, if I'm not mistaken. So the participants were mainly men, among which 16 were MSM. They had 41 nationalities, mainly from Africa and Asia. And the risk factors that they had identified for the increase of STIs, because the STI prevalence was 73%, which is, in my opinion, above the expectation even. So the risk factors were not using a condom and having had several partners in the past 6 months prior to the study. These factors are not really surprising. However, the STI prevalence seems to be very high. On top of all the STIs burden that I mentioned, we have to keep in mind as well the gender migration and violence that is experienced by people or can be experienced by people. And here it was a little bit shocking, even to me, when in Malta again they had another study, and this is much more recent, and they had a reported number of 28% of migrant had female mutilation. However, 12 confirmed victims of human trafficking for sexual exploitation, and many, as you see, had experienced sexual violence, such as rape, assault en route, and intimate partner violence. So it's a little bit also of a psychological trauma that should be kept in mind as well, as long as we are talking about STIs and HIV in the migrants and refugees. Going back to Lebanon, this is a very interesting study that was also conducted by or overviewed by Rina and other colleagues and the National AIDS Program among in Lebanon. Among refugees, 178 refugee women, they had seen two cases of chlamydia and one case of trichomoniasis. This is another paper that is more qualitative, and it's very important to shed the light on this paper because it really identifies main themes that contribute to the increase of STIs among the population or the subpopulation of refugee women in Lebanon. So, in terms of society, we have here the patriarchal gender norms and stigma, which you might not see in other countries. In Europe, for instance, this will not never be taken as a factor. The extreme poverty and insecurity at the community level, we see the sexual harassment, the transactional sex, the sexual exploitation, and the poor care accessibility. Interpersonal, we have the intimate partner violence. At individual level, we have the social isolation and the internalized stigma and guilt. And all these factors together as social determinants of health will contribute to the increase of STIs. And there are other factors related to STIs, such as challenges in partner notification. We know very well that partner notification, for instance, in countries like Lebanon and the surrounding countries, and even in some countries in Eastern Europe, this whole policy and tool doesn't work at all. Another paper from Lebanon as well, and so this paper we had published it in 2021, and the real objective was to look at the percentage of STIs in a large cohort of men who have sex with men. However, we found out later during the analysis that many were nationals and refugees, and that's why we changed the whole narrative of the paper. So it started at percentage. As we see here, the percentages are really high for some STIs, such as condyloma, HPV, chlamydia, gonorrhea, really above 10%, herpes, even syphilis, it's 10%. However, if we look at the difference between immigrants and refugees and the nationals, we will see that gay and bisexual men who reported to be immigrants or refugees were more likely to report a non-university level of education, a heterosexual marriage with a consequent bridging of STIs across couples, engagement in sex work, a past diagnosis of syphilis for people who are immigrants or refugees, an experience of stigma by healthcare or employment workforces, a lower STI knowledge based on the STI knowledge scale or score, and a higher number of male sex partners. So we really had all the factors that can contribute to an increase of STIs among this population, and we're talking here again about Lebanon. And we had experiences in dermatology. Sorry, again in visiting and many groups across Lebanon of dermatologists. Many groups really went to several camps to provide some skin disease services, and this trip, for instance, was in, or this project was in 2014-15 with Professor Morone, and it was a very interesting and important learning curve because seeing leishmanias at a daily daily pace is really challenging. However, in the camps, we could see them very frequently. Even in the private clinics, we were seeing a lot of cases of HIV, diagnosing them, many cases of syphilis, condyloma, pediculosis, etc. Now, let's move to solutions and next steps. So, the overall interventions that are identified in the literature, there's no magical or secret recipe that can work anywhere. There are really interventions that are tailored to the factors belonging to the social determinants of health that are contributing to the factors. So the first thing or the first step of the exercise is to identify the factors that are contributing to the increase of STIs, and then the interventions will be secondary because they should address these factors. So we're talking about comprehensive interventions, but what's the translation of this title? It should be really individual, organizational, and structural components. It should include these three as identified in the social determinant of health. And it's really a checklist exercise where you identify the factors and then you try to address them one by one, but then the overall will be a comprehensive intervention. And they should be focused. Some factors that can work, or some interventions that can work in Malta, for instance, do not work in Lebanon. Some experiences in Malta do not work in the neighboring Italy even. So really interventions should be focused and address specific individual attributes such as knowledge, attitude, perceptions, and behaviors. I was always discussing with colleagues in other countries about knowledge. For instance, in Lebanon, knowledge is not usually very low in terms of STIs and HIV. It's not an extremely high, but it's not as low as other colleagues in other countries see it, because people are aware about the sexual behavior that are at risk. However, they don't follow the preventive tools that are required or advertised or offered by the healthcare workforce. The interventions, as I said, should tailor across to all the papers that are published, the individual, community, and structural types, and they should include these three pillars. So each intervention should include these three pillars. And there are a lot of papers actually and a lot of textbooks about how to address and how to define first these three pillars and then how to address them and what is included in everyone. And as an example here, this is a project that is again led in Malta. It's actually in Malta, Greece, and Italy. So it's a three-country project that where where healthcare workforce is offering an increased capacity in terms of STI testing, and they have specific targets, and they are achieving many of them. However, this is their only way to be able to educate, to increase awareness, but also to capture people who test positive and to give them same-day treatment. So a minimal project with a minimal budget can really make a certain difference. And of course, we have to mention the multi-country collaboration. And this project had already started in Lebanon for a certain period of time, 2023. It's still ongoing in certain camps, in certain regions in Lebanon. So, and if you look at the red numbers here, the numbers flagged in red, you will see that many people would understand a little bit of STIs or how it is transmitted, would know about the preventive method. However, the attitude in general is really negative. And this is a cultural thing, and it's not only characteristic of Lebanon, but it's also across several countries. And we'll see that people usually are verbally abused when they are living with HIV, or they have a certain fear of being left by partners, for instance, so they don't disclose their positive serology. And regarding the practices, you will see that there are some instances, and this is only in Malta. I'm not talking about Lebanon. So this slide is about Malta. We see that there are people who had sex against their will, or they couldn't seek medical care, etc., etc. And I hope in the near future we can have the overall total results of the SCAP project in Lebanon and Malta. So the cooperation that I mentioned also, so it's not only about determining the key factors or the key factors that contribute to the increase of STI, but it's also about cooperation, and the collaboration should be across borders. It's not only about NGOs that are working within a country, it's more to bring on the table the people or the stakeholders that belong or work at NGOs, at public entities, and also research institutions to share good practices, to learn and to strengthen the disease control, and to have much more inclusive health policies as much as possible to ensure migrants have access to consistent health care, regardless of their location or legal entitlement, and of course to promote the intervention to increase awareness and offer integrated community testing. This is the most important step. But of course, it needs a lot of coordination before being able to, and of course, it needs also financial support to be able to implement an integrated community testing, whatever is the community. It can be the community of refugees or of migrants or of men who have sex with men or of sex workers. But however, it should include people who are or who belong to the migrant status or refugees. And to target, of course, the disadvantaged groups and migrants from LMICs. At clinical level, we should, this should be a cross-disciplinary partnership across several healthcare workforce entities, from the dermatologist to the nurse, to the surgeon, to the pharmacist, to the social worker, who can contribute all together to implement this work. And all what I said is in line, actually. We're not creating anything. We're just reframing what has been said in the global health sector strategies that were endorsed by member states in regard to STIs, because we were talking about creating an environment that encourages people to discuss STIs, scale up primary prevention, increase the integration, accessibility of people-centered services through public and private sectors, close the gap in funding. We are facing a huge funding cuts at the moment at the global level, facilitate the adoption of point-of-care diagnostics and other new effective technologies. And in Malta, they are trying to look into an AI-based tool that can help diagnosing some anogenital dermatoses and STIs, and of course invest and facilitate research. So it's really the same puzzle that's being discussed at any time, but we need really to put more efficient interventions, and controlling this issue of STIs among migrants will not be only beneficial at country level, it will also help us achieving our SDGs. And if we look at these titles only, we will see that the topic that we have been discussing for the last minutes fall under almost each of these SDGs. So from the good health and well-being to the quality education to gender equality to the reduced inequalities, they all fit, but they just need to be implemented at country level. And with this, I want to thank you.
Thank you, Dr. Maatouk, for this very insightful presentation. Your discussion really sheds important light on the challenges surrounding this topic. So right now we're going to open the floor for questions. If you have any question, please place it in the Q&A box. I believe we already have some, so we'll start by addressing those. So we have a question from Richard. Thank you for a great presentation. I was wondering about the access to medication, especially diseases that require chronic medication. What do you think the best approach to ensure the access to this medication can be maintained for people living in shelters or for the people on the move?
So thank you so much. This is a very important question. For instance, for HIV, we had a similar problem for the chronic medications of ART, and one of the major tools that was very useful is the dispensing at community level. This was one way, for instance. It depends on the local and the logistics, but this is one tool that I remember very well. It worked very well and perfectly, and it's still working in Lebanon, for instance. The dispensing the medications at community levels.
Thank you, Dr. Maatouk. Another question, does limited awareness among refugees lead to more advanced or complicated STI cases? How can dermatologists approach these situations to start an open, culturally sensitive discussion about sexual health?
Well, I have the same question as well because we try our best as dermatologists. I mean, things are better with dermatologists now because even the International League of Dermatological Societies is now on top of the STIs. But of course, it's not the big number one priority for dermatologists. However, we are being heard much more than before.
Thank you, Dr. Maatouk. And the last question I have here is considering that many refugees have limited health literacy and often rely solely on healthcare professionals for diagnosis and treatment, how can we strengthen awareness and empower them to understand and protect themselves from STIs or to ensure that they get the right treatment themselves?
So again, back to the experience in Lebanon, we were doing awareness for the general public and for populations, but we found that the best way is for peers to be able to deliver the message. So the same message that comes out of a professional will have a different impact when it is channeled through the peers. And I think that having a very strong and active community, people who are really working, I mean, refugees or migrants who really understand and then they train themselves or they provide the sessions is much more useful and impactful to the communities than being us giving the same messaging. I don't know if I was clear.
Yes, thank you, Doctor. And so the last question is, will the presentation be shared and the recording? So I'll answer that. This week we will share with you the recording. And of course, if you have any queries, do not hesitate to reach out. We'll be able to support on that. I believed we addressed all the questions. I can see no more new questions here. So thank you, Dr. Maatouk, again for taking the time to share your expertise and your experience with us today. And thank you everyone for attending, for joining and engaging in this important conversation. We look forward to welcome you in our upcoming webinars and have a wonderful day, everyone. Thank you.